Okay, let's move on now to lumbar stress testing. All right, so we'll be looking at lumbar, spine and sacroiliac joint stress testing. Now these are obviously not ligamentous stress tests, or at least not individually so, but segmental stress tests, and they are not individual segments neither. This is for the region rather than for a particular segment. Now, generally speaking, when you're doing ligamentous stress tests, you're looking for the reproduction of pain and instability. At this stage of the examination, for the most part, we're interested in the reproduction of pain because instability, while you can pick it up with these tests, is really can be quite subtle. And you're better off using biomechanical stability tests rather than these sort of gross regional tests. So we'll be looking at compression and distraction, torsional stability testing, PA stability testing, and sacroiliac joint stability testing. Okay, so starting with compression and traction. With compression, we'll be applying axial compression along the line of a spine, and this will basically be testing for stability of the structures responsible for vertical stability. So we're looking at the disc itself, the vertebral body, the end plate. So it will tend to show up vertebral body fractures, disc prolapses, and end plate fractures. However, with the reproduction of pain, where we're looking for that, if we have an acute arthritis, traumatic or otherwise, this test is often positive also. So it is really best done on the patient where they've had a chance for any arthritic condition to subside, so that you know that you're dealing with something non-arthritic. So, to produce this compression, we bring the patient towards us across the bed this way. Flex the hips and knees so that the pelvis just starts to rotate off of the bed that way. And then I'm going to apply pressure which will tend to move the patient along the bed. Okay? And the pressure will be through the feet, while my arm around the knees stabilise the knees and stop these over flexing. And if we can look at this a little bit more distantly, maybe a little longer shot here, then you can see my body position is like so. So I'll be pushing here and stopping flexion occurring here. The pressure comes from my right foot. So I'll just push up the bed as if I want to move it along the bed that way. And in fact, the bed moves with me, which is the right movement that we require. We're looking again for pain and particularly a spasm end feel. Now, if the patient has a positive test before you can even apply the compression, you get them up to about this position and they get a lot of pain, then it may be that you've got a very positive test on your hands. You haven't applied the compression though, so it simply could be the flexion that's doing it. You can still apply the compression from here, but what you have to do is bring the legs down lower so that you're still pushing parallel with the bed. There. And it's the same force to move the patient along the bed, or in this case, the bed along the floor. The opposite to this is obviously traction, and we'll be applying an axial traction force, which is going to test the structures running longitudinally. And it will be mostly sensitive, presumably, for the long ligaments and perhaps the muscles. To apply this test, you don't have to get on the bed with the patient and sit on their feet or anything, but move the patient down towards you. They put their feet on your thighs this way, link your fingers underneath their calves, and you simply lean back to apply your traction. And you can apply some really quite strong traction, and as you're only applying it for a few seconds, you don't have to be more formal about it, as your tissues will stand up to a few seconds of this quite nicely. And again, we're looking for the reproduction of pain when we do this. Okay, can you lay on your stomach for me? Torsional testing. Again, it's general, although it can be somewhat segmental, and we'll look at that in a second. But basically, what I want to do is stabilise about T12. Okay, in fact, don't stabilise above T12 because you're going to get a lot of rotation. Now, we're going to produce axial rotation. Now, there is only about 1 degree of axial rotation per segment in each direction. So we don't want to see the pelvis coming way off the bed when I lift up. I'm also looking for the reproduction of pain. Now, this is testing the structures that restrain torsion. So we're looking at the annulus, particularly the fibres that are running upwards and in that direction. And we're looking at the apophyseal joints, where it will impact on the opposite side to the way we're rotating. So if I'm pulling the right pelvis back, I'm actually testing left torsion, which would test the right apophyseal joint. Once again, though, if I have an apophyseal joint arthritis, this test will reproduce pain. Okay, so we'll stabilise, grab the anterior iliac spine here, and simply pull it straight back towards me, and that's about how much movement I should get. Very little, and the end fill should be just about bony. Now, to test the other rotation, don't test it this way because you can't get the stabilisation. It's a different test. Go around the bed and retest it from the opposite side. Okay, postero-anterior pressures. What we're looking at here is I'm pushing one vertebra down towards the bed, and this is going forwards over the one below it and under the one above it. So let's say, for instance, I'm pushing L3 anteriorly, then it's actually producing an anterior shear on 4 and a posterior shear on 3. So this test doesn't tell me whether it's an anterior or posterior instability. In addition to that, as I push down, the vertebra above and below it actually rotate, so I extend both segments. So it's also a mobility test. So as a stress test, it's fairly weak. But in this stage of the examination, it's pretty good for what we need. Now, if it's positive, it could be that there's instability there. It could be that I have a joint problem or a disc problem. So I'm looking again for the end fill, which should be nice and springy from the disc, and also the reproduction of pain. If I get spasm, I'll get a very non-resilient end fill, and possibly even it will kick back at me as I do this test. The way I like to do the test is to put my pisiform over the spinous process this way, or the pisiform area, and then just reach over with the other hand so that the index finger and thumb palpate the paravertebrals on either side, so that I can pick up, when I push down, any paravertebral spasm under the fingers, like so. So starting from 5, I just lean forward, take up all of the slack in it, and then just apply a little bit of overpressure to provoke any spasm and symptoms. And I just move up the spine and check each one in turn. Now, this is a very gradual force, and it doesn't want to be sharp and sudden. Okay, all right, so there are the stress tests for the spine in general. The torsional stress test, as I said, you can make a little bit more segmental if you really want to. Although the segmental tests done properly are better. But to do it in the same fashion, all you do is you stabilise the spinous process of the lowest one, 5, and I just push it that way, pull the pelvis back, so I'm testing L5S1. Move up onto 4, do the same thing, and then 3 and do the same thing. And I should see a slight increase in the range at each one I go to, not much. But again, I'm looking for one segment really allowing a lot of movement and or becoming painful. However, you have to stop at the first positive segment, because to go higher than that, you have to go through it and you're going to pick up that positive again.